we're limited there.
I'm free.
Okay, it looks like we are live. Welcome to the first NephJC Hangout. I'm Joel Toff. We have Paul Phelan with us, and we have Vlado Perkovic. Did I get that last name right, Vlado?
You did, Joel. Well done.
Excellent, excellent. I'm a nephrology blogger at pbfluids.com, and I'm on Twitter at Kidney Boy, and I'm one of the founders of NephJC. Paul, do you want to introduce yourself?
Yeah, I'm Paul Phelan. I'm a nephrology research fellow at Duke. I'm a contributor at Renal Fellow Network.
Excellent. And Vlado, why don't you tell us a little about yourself?
Sure. So I'm a renal physician in Sydney, Australia. I'm Professor of Medicine at the University of Sydney and Executive Director of an academic research organisation called the George Institute for Global Health. I was a member of the steering committee of the RaDaR trial.
Excellent, excellent. So, and that's relevant because the RaDaR trial is the trial that we're talking about today. Or actually, we talked about last week in the first NephJC. Paul, can you give us a quick rundown of what this paper was about?
So, this study was a kind of reincarnation of endothelin antagonists. It was studying Atrasentan, which is a selective ETA antagonist in diabetic nephropathy. So patients with proteinuria, relatively preserved kidney function. And it came on the back of the Ascend trial a couple of years ago, which was looking at Atrasentan, which caused a bit of a stir. It certainly in preclinical trials had shown improvement in albuminuria, but the trial was stopped early due to an excessive cardiovascular events, which was mostly heart failure and fluid overload. So this study, one, it looked at a slightly more specific ETA antagonist, so Endothelin-A receptor blocker, and also the authors have to be commended for carefully selecting their patients to, I suppose, try and minimize the adverse events seen in the Ascend trial. And I think Vlado could probably tell us a little bit more about that.
Yeah, Vlado, what do you want to add about RaDaR?
So I think a few comments to make first up. Firstly, this is a group where we desperately need new treatments. We haven't had anything new that helps to reduce the risk of kidney failure in people with diabetic nephropathy really since the Renal and IDNT trials, which were the best part of almost 15 years ago now. So, and even in those trials, the risk of end-stage kidney disease was sort of pushed back several months, but remained very high, even in the group that got RAS blockade. So we need additional treatments to further try and reduce the risk. And we see all across the world now diabetes becoming the major cause of kidney failure and an ongoing growing cause of kidney failure. So it's a really important public health problem too. As Paul said, endothelin antagonists show promise in this area. There's been data for quite some time now suggesting that they reduce albuminuria, and indeed some preliminary data with Atrasentan, the endothelin antagonist used in RaDaR, showing the same thing. But as was shown in the Ascend trial, and as has been known with this class of agents, there's a tendency to cause fluid retention, which can result in heart failure in some people. So the question really was whether you can find a way to get the potential renal benefits of this class of agents at the same time as minimizing the risk of adverse events. And that's why the RaDaR study was designed.
Yeah, I think that's a great point. When I was prepping for this this journal club, I went back and I looked at IDNT, and I just looked at what the change in GFR was, and it was an average loss of GFR of 5.2 cc's per minute per year with the control group, and 4.4 cc's per minute per year in the irbesartan treated group. So, I mean, there was still dramatic loss of renal function even with full treatment. And I think that's a great point. Is that we do, and ACE inhibitors and angiotensin receptor blockers are not enough. These patients are still progressing to end-stage renal disease, and we've not stopped this disease by any means.
The GFR issue is something which is very important, and I think it's notable in this study. Like as you say, Joel, we're used to seeing changes in albuminuria and changes in GFR go hand in hand. With RAS blockade, we expect to see a drop in GFR, and we accept that for the improvements in albuminuria. We were all caught out then by bardoxolone, which I suppose could be thought of as the anti-ACE inhibitor, where we actually saw an improvement in GFR, but at the expense of increase in albuminuria, and then we all know what happened with bardoxolone. So I think it's crucial that in this study we did see an improvement in albuminuria on top of what we already see, and these patients were maxed out on ACE inhibitors, but that was seen in patients with a stable GFR, so that's encouraging.
Yeah, and I think the thing to think about with RADAR is that this is a stepping stone study. That if Sonar, and we're going to talk about that later, if Sonar ends up being successful, and this drug really does slow down the progression of kidney disease, I want to hear about the endpoints and all that. But if it is successful, no one's ever going to remember this study. This is a study that allows us to take the next step, which is going to be the definitive study, which is Sonar. Vlado, do I have that right?
Yeah, I think that's right. I mean, you could consider it the equivalent of the IRMA-2 study, which preceded IDNT and renal, and really was the equivalent of this study looking at albuminuria endpoints that were subsequently confirmed in a larger outcome study. And that's the approach we've taken here, aiming to identify the patient group and the dose of the drug that's most likely to give us the best outcome for those patients, and then using RADAR and then testing that in a subsequent hard outcome study.
Yeah. Yeah, and that's actually a good point. Is that the dose finding study was a super important aspect. Is that there was in addition to the placebo, there were two doses in this study. There was 0.75 and 1.25.
Right.
And that importantly, there was no difference in the beneficial effect of the drug between those two doses in terms of reduction in proteinuria. They were equal in reduction of proteinuria, but we did have increased adverse events, kind of in a strange way to measure it. It was only different when you looked at adverse events that required stopping the drug.
Yeah, that was a slightly unusual result, but I think the more important point was the one you made. We had previous data showing that 0.25 was really not very effective at lowering albuminuria, showing that higher doses caused unacceptable side effects. So this trial looked at two doses in between and showed that both of them produced equivalent albuminuria reductions, but that the adverse effects were much less in the 0.75 than the 1.25. The other important outcome in the study was change in weight. And in the higher dose, weight increased by about 1 kilo and stayed high throughout the study, consistent with what we'd expect to see with fluid retention. In the lower dose, there was less than half that amount of fluid retention initially, and by 3 months, the weight had returned to baseline, suggesting that while there still is probably some degree of fluid retention, it's less, and it's less likely to be problematic than we'd get with the high dose, which is why the lower dose has now gone on into the hard outcome study.
On that point, Vlado, and obviously Sonar is going to tell us more, the authors of this trial, yourself included, obviously were very meticulous in choosing the patients to try and, like as I said, maximize benefit and decrease harm. If this drug gets approved, us clinicians in the clinic are going to have to be equally as meticulous in identifying which patients are going to benefit from this. It appears that the drug has a rather narrow therapeutic index, and it's just something worth noting. You guys obviously did a great job identifying the correct patients, so it seems it's going to be a drug that we're going to have to think long and hard about who actually gets it.
Yeah, look, this is an ongoing issue for us with all treatments. If we think about RAS blockade, if we have a patient with a potassium of 6, we're going to be very, very careful about introducing a RAS blocker in that particular patient. And it's a bit the same here, except the adverse effect is a bit different. It's fluid retention. So if you've got somebody or in heart failure, you might want to presuming the trial's positive, we'd certainly expect those things would need to be controlled before we consider adding an endothelin antagonist. That said, it's likely that there'll be a large proportion of those people at risk of kidney failure who would fit the criteria, be eligible for the drug, and potentially benefit from it. The other important thing I think to make about the new trial Sonar is it's got a really exciting new design which uses what's called an enrichment approach, where all patients who enter the study and who go through the screening phase will get the drug for 3 months to see whether they get a reduction in albuminuria. And then the focus of the subsequent trial will be those people who get that reduction in albuminuria. At the same time, about 1,000 people who don't have a reduction in albuminuria will also be randomized. So this trial will be the first trial to give us some sort of reliable information about whether change in albuminuria predicts change in outcome down the track, which is one of the key questions that all nephrologists as well as the regulators have been struggling with for many years now.
Oh, that is fascinating. So you know that some people that take this drug don't get a reduction in albuminuria?
Yeah, so about half of the patients who entered the study got more than a 30% reduction in albuminuria. Most of the rest got a lesser degree of reduction. Some people had no change or even a slight increase. And that's typical with what we'd see, for example, with blood pressure lowering agents if we use them, partly because of the variability in measuring, partly because of the range of factors that potentially influence it. But if we believe the hypothesis that change in albuminuria predicts subsequent benefit, then we should focus on those people who got the reduction to subsequently. What we're doing in this trial is we're also looking at a group of those people who don't get the reduction to see whether they benefit as well or not. And so from that perspective, we'll be able to finally get some information about how well that predicts outcome.
I'm sorry. Isn't this going to mean that almost all the people in the people that don't get a reduction in proteinuria, isn't that where all your placebo patients are going to end up?
So all of the patients are getting the drug for 3 months, and then those who have the reduction are subsequently randomized to continue the drug or get the placebo.
Okay. So yeah, so I think that a little bit further discussion about Sonar is really what we're looking for, because that's going to be the definitive study that's going to really determine where this drug is going to go. So you say everybody enrolled in the trial gets the drug
for 3 months. It's equivalent, if you like, to the active run-in phase that's often used in trials to assess side effects. But here we're looking at efficacy as well. So it's a novel design for a renal trial. It's something that has been used in other areas of medicine for some time, and something the regulators are generally quite keen on. But it will be, it's quite exciting for us as a nephrology community. Sonar more broadly will recruit close to 5,000 people with diabetic nephropathy from around the world. It's going to be a massive study and a massive effort to achieve it. And it's begun and is underway, and we certainly need the support of the entire nephrology community to make sure that the study's delivered, and we can all benefit along with our patients from the results down the track. So that's going to be a big job for us for the next few years.
So I'm sorry. So everybody gets the drug for 3 months, and then at that point they randomize to either placebo or 0.75 of Atrasentan.
Right. Those people who tolerate the drug then get randomized.
Okay. And the endpoint that you're looking at is
a hard renal endpoint. So it's a composite of end-stage kidney disease, so dialysis or transplantation, or renal death due to progressive kidney failure, or a doubling of serum creatinine. So that's classic. Okay,
so this is a conventional endpoint that we've seen in dozens of studies.
Yes, it's a variant of, yes.
Okay, and how long is this going to take?
Well, it'll take at least
presuming it doesn't stop early. Okay, let's give you the benefit of the doubt.
We expect it to take at least another 3 or 4 years before we are likely to get a readout. So we've got a long way to go. We're still in the early stages of recruitment, and there's a lot of work to be done. But hopefully, sometime in 2018 or thereabouts, we'll start to get some results.
So you think in 2019 it'll be at the late-breaking trials of Kidney Week?
Something like that, yes.
Oh my God, that's a long time from now.
Yeah.
Vlado, just to clarify, the patients that are going to be enrolled, it's going to be similar to radar in that, overt proteinuria, some renal dysfunction, but maybe not as severe as Ascend.
Yeah, so it's macroalbuminuria and an EGFR of between 25 and 75. So they're the high-risk patients. These are the group who are most likely to go on and develop renal failure based on analysis of a large number of data sets.
Or have
you said GFR 25 to 75?
Yep.
Okay. Okay.
Right.
Vlad, do you have any final points that we've not covered, or things that you thought that were not brought out well in the journal club that you think is an important point about the Atrasentan trial, radar?
Look, I think we've covered most of it. It's an exciting opportunity. It's an exciting potential therapy for our patients, but it has to be proven in an appropriate trial looking at hard endpoints. So that's where we're at the moment, and we need all of your help.
Yeah, I am very excited and interested in seeing how this turns out. Very excellent. Thanks a lot. Thank you for joining us, and thank you for participating. If you'd like to stay on, that's fine. We're going to introduce our paper for next week. Next Tuesday at 9 o'clock, we're going to be talking about the Simplicity trial that was recently published in the New England Journal of Medicine. Paul, do you have any immediate thoughts on Simplicity?
It's going to be controversial. As you know, Joe, we've had a lot of Twitter chat about it. It was a study I was really looking forward to, and I must say I bought into all the hype. I don't necessarily think renal denervation is dead, but it's joined the nephrology collection of the New England Journal of Medicine as being a graveyard study, unfortunately. So I'm looking forward to the chat, but I still think there's possibly patients that we can use it on, but more work is needed.
Yeah, I agree. I think that this was one of the most exciting aspects of renal therapeutics to come by, a completely novel way to tackle hypertension. A lot of the data was very exciting, and I think in the end there's real lessons to be learned about placebo-controlled trials, and that there's no substitute for really making sure that patients are given good active treatment in placebos, so we know if this drug really works or if we're really just dealing with an illusion. Yeah. Vlado, any thoughts on Simplicity?
Oh, I think it's a fascinating trial, and I think there's going to be a lot of discussion of it for some years to come. The question is, which data is right? Is Simplicity 2 or Simplicity 3 correct? Because they can't both be, I guess.
Excellent, excellent. So, that's where we're headed. We're going to try, the kind of the structure for the NephJC going forward. What we're going to try to do is we're going to try to do a journal club on one Tuesday, then the following Tuesday follow up with a little video summary of the discussion, and then announce the next journal club, so that every Tuesday night there'll be a little bit of content from NephJC. We've got the next few journal clubs set up, but we're still going out to mid to late April. We're looking for different submissions. So if you are watching this, please drop us a line. You can go to the nephjc.com and fill out a form there to submit one, or just tweet it with the hashtag NephJC. Paul, any final thoughts?
No, I just want to thank Vlado. He's been very obliging both this week and last week. Thanks for coming.
Yeah, I completely concur with that. Vlado, this was excellent. Any final words there?
I just wish you all the best with it. I think it's a great initiative.
Hey, thanks a lot. Thanks a lot. And to everybody that was watching or is going to be watching, thanks for joining us, and we'll see you next week on Twitter. Take care.
See ya. Bye-bye.